Good afternoon for all who join us. We are extremely pleased to welcome you to this new webinar in the name of our society, the European Society for Contraception and Reproductive Health. Today, we have a very exciting webinar during which will be presented for the first time, released for the first time, a new study conducted on the pill containing estradiol combined with normegestrol acetate in real life and addressing the question of safety and efficacy of this pill compared to other kind of pills. So my co-chair is Professor Ali Kubba, who is the vice president of our society. And myself, I am the secretary of the society. And we have two excellent speakers. The first one, Franca Fruzzetti, will present the result of this new release study. And then Professor Calaf will discuss the place of this new, it's not really new pills, but the results obtained by this study in the scope of contraception. So the two speakers will present successively their talks, and then we have kept a lot of time for discussion. So please do not hesitate to ask questions. We will explain you how to do that if you are not familiar with the Zoom device and webinars. And so we are very excited for about this webinar. So next slide, please. Next slide will present the context of this webinar. Theramex has provided financial sponsorship for this non-promotional webinar. We have selected the speakers, and Theramex have reviewed the webinar content for factual accuracy. But the text and the content of the speakers, of the talks, are totally to the speakers' decision. The views and opinions of the contributors in the webinar are not necessarily those of Theramex. Next slide, please. So I will present now the advantage to become a member of our society. The fee is very low for an international society, as you can see here, because it's a 60 euros fee per year. And paying that fee, very low fee, you will have 6 free editions. You will get 6 free editions of the European Journal of Contraception and Reproductive Health Care, the journal of our society. Actually, we have decided to move to online access only, no more paper copies. You will receive regular newsletters with updates about contraception and reproductive health. Free access to our webinars. Some of them are on free access and some others are reserved for only members. You will get reduced registration fees to our congresses and events. You can state for election to the board, and you can access to this quite new tool we have implemented. I will present it in the next slide. It's a platform for the society, reserved for the member of the society, where very, very active discussion on a forum are conducted about various subjects. Furthermore, if you are part of an European organization, if this organization has at least 10 members, then you can be affiliated through this organization with a reduced fee. Next slide, please. So we will have, hopefully, our next Congress in Ghent from the 25th to 28th of May 2022 in Ghent. And you can still submit your abstracts until the 1st of November. So please do that, because we have seen the program, and I am sure it will be a success. The program is also very exciting. Next slide, please. So what is Doc Matter? It's again a platform, a forum. You can have access to that if you are a member of ESC. And this tool, which has been implemented this year, is very, very active, with more than 1,000 participants on various subjects. I think the next slide will present in detail these areas and discussion about reproductive health services, the impact of COVID-19 on patient care, contraception, of course, ovarian, breast cancer, patient education, remote consultation, etc. So it's really an interactive, extremely dynamic platform to ask questions and to get answers from all over our members. Next slide, please. So now I will present the practicalities of this for this webinar. So if you want to ask a question, and please do not hesitate to write a question during the talks, and then we will address, as I already said, at the end of the talks, the questions and ask to the speaker to answer to them. So you have to click on the Q&A button. You can upvote each of the questions with the thumbs up sign. A selection of questions will be selected after the lecture, and our experience is that we cannot have time to answer to all questions during the webinar, but don't worry, the unanswered question will be addressed and their responses will be put on our website. So again, become a member to our dynamic society. It's a cheap fee, and you will get a lot of benefits, I am sure. So now I will introduce the first speaker. It's my privilege to introduce Professor Franca Fruzzetti. She's professor in the OBGYN department at Cerra Hospital in Pisa. She's an expert and has already published a lot of papers about reproductive health and contraception. And she will thus have the privilege to present the results of the study of prospective study on the NOMAC estradiol contraception in real life, on safety and efficacy. So now, Franca, it's your turn.
Thank you, Anne, for your kind presentation, and thank you to all teams over the organization of this very interesting webinar. Okay, the title of my presentation is the highlights from the Creu observational comparative safety and efficacy study. And these are my disclosures. And in my presentation, I will present preliminary data evidenced by the past study with the oral contraceptives containing 7-beta estradiol and nomegestrol acetate. And the first question is, what is a PAS study? PAS, it means a post-authorization safety study. It is a study requested by the European Medicine Agency this design to characterize the safety profile of any kind of drug we enter in the market. And this kind of study is requested also for hormonal contraceptives. And also in this case, the study is designed to characterize the risk profile and the clinical profile of any contraceptives we enter in the market, in the attempt to have data from a real life setting with the aim to provide an up-to-date information to women to assist them at the time of the choice of contraception, and obviously also to assist the clinician at the time of the prescription. And until now, it has been performed one Pisa study, the one with estradiol valerate and the Enogest. The study included more than 10,000 women and demonstrated that these contraceptives was associated with a similar VTE risk compared to contraceptives containing ethinyl estradiol and levonorgestrel. And looking at hormonal contraceptives, one of the major concerns of these combined hormonal contraceptives is the possible risk of cardiovascular disease. And venous thromboembolism is an uncommon but potentially serious adverse event linked to the use of combined contraceptives. And the slide showed the graph is a meta-analysis of the risk of venous thrombosis reported with the pills containing ethinyl estradiol. And as you can see, as a result of this meta-analysis, the risk of VTE is about 3 times higher in users of combined hormonal contraceptives with respect to the non-users. But actually, when you look at the absolute number, the numbers are very low, because low is the spontaneous risk, the number of the event in the non-user population in the reproductive age. As you can see, the number is, depending on the different countries, range from 1 to 5 per 10,000 women years, and in users of oral contraceptives, the number rises to 3.9, in some studies reported 12, but in any case, the risk, the absolute number are very low and lower than that occurred during pregnancy and in the postpartum period. And the venous thromboembolism is mainly related to the effect that the estrogenic component of hormonal contraceptives exert on the coagulation factors, activating coagulation. And the changes of coagulation, however, depend on the dose and also type of estrogen. And estrogen have, in general, a different effect on the synthesis of hepatic protein. As you can see in this graph, the effect of natural estrogens is much lower than that of the synthetic ethinyl estradiol. In other words, ethinyl estradiol exerts a very strong effect on the synthesis of hepatic protein and also on the factors of coagulation. And because this different effect, natural estrogens induce less changes in coagulation factor than ethinyl estradiol. In this way, the consequence, it is a possible lower risk of VTE with contraceptives containing natural estrogens. And as far as progestins have no direct effect on coagulation, but they are able to modulate the effect of estrogens on coagulation. And this way also they are able to modify the VTE risk due to estrogenic component. In particular, looking at the pharmacological profile of progestins with androgenic activity, such as levonorgestrel, are those we are more able to counteract the effect of estrogens on coagulation. And in this way, obviously, if you look at the number of venous thrombosis reported with combined pills with ethinyl estradiol and associated with different progestins, it is evident that the risk vary according to the type of the progestin, and the progestin contain and hormonal contraceptives containing levonorgestrel are associated with the lowest risk of VTE. And as far as the arterial thrombosis, the risk is very, very low. This is the number of additional events per every 10,000 women, so very, very low. And eventually this risk is mainly reported in women with other risk factors such as obesity, cigarette smoking, and hypertension. And in the first decade of years 2000, a monophasic pill became available with 70-beta estradiol and nomegestrol acetate. As you know, is a monophasic pill with an extended regimen, and the association contain 1.5 milligram estradiol and 2 milligram of nomegestrol acetate. Nomegestrol acetate, just to remember, is derived from progesterone, is a progesterone derivative. It has a strong affinity for the progesterone receptor, and also it has a strong antigonadotropin properties. It is devoid of estrogenic, androgenic, glucocorticoid, and mineral corticoid activity, and it has a very moderate antiandrogenic activity. And also in this case, in line with the European policy, the European Medicine Agency requests a PAS study for also the association NOMAC-E2. And the study has been also named PRO-E2. And this study has been performed to assess the cardiovascular and heart health risks associated with the use of the NOMAC-E2 contraceptives compared with the use of contraceptives containing levonorgestrel. Why levonorgestrel? Because actually it is considered the contraceptive with the lowest venous thrombotic risk. And the study has been powered to demonstrate, to test the non-inferiority of the association with NOMAC and E2 versus the products containing levonorgestrel. Okay, the study is a multinational, large prospective, non-interventional study, is a cohort study. 12 countries has been included in this study, but actually the data from Mexico has been canceled from the last analysis. The cohort were two kinds of pills, so women taking the association E2 NOMAC and the other, the contraceptives with levonorgestrel. Were included in the study new users, so first users, and restants mean women who have a washout period for 2 or more months from other intake of hormonal contraceptives. The recruitment target is 101,000 women, and the intended to treat population, as you can see, was quite similar, so a very large study. And the study, there are two different stages. The first one is the recruitment study, and the second one is the follow-up study. The follow-up study terminated to September 2020. And the participants are followed for a minimum of 1 year and a maximum of 2 years. And as you can see, this is the number of women enrolled, and this is the number of women with available data to be analyzed for the safety outcome, so very large number. Okay, the study, I remember again, is designed to test the non-inferiority of the NOMAC-E2 treatment regarding the VTA risk in comparison to COC with levonorgestrel. This is the study participant. Women were taking the association with NOMAC and other with the levonorgestrel. As far levonorgestrel, the kind of contraceptive users use type were monophasic pills with 20 and 30 microns of ethinyl estradiol, and some people received the prescription of a multiphasic preparation, but always with levonorgestrel. If you look at the S-treated population, as you can see, the number, the percentage of women who received the NOMAC and those who received the levonorgestrel are well balanced. And as far as the product containing levonorgestrel, as you can see, the majority out of them received a monophasic preparation. Again, the recruitment of study participants was conducted by healthcare professionals who participate in similar cohort study, and they recruit patients in an approximate 1-to-1 ratio, and there were no specific medical inclusion or exclusion criteria and no age restriction, but women with particular risk factors for VTA, such as story of VTA or thrombophilia, or they have a history of cancer and chemotherapy, has been excluded from the analysis. And based on the request of the European regulatory authorities, the primary outcome of the past study was to see the VTE risk, in particular deep venous thrombosis and pulmonary embolism. Secondary outcomes were all VTA, so the superficial VTA, arterial thromboembolism, depressive disorder, as you can see, cholelithiasis, inflammatory bowel disease, acne, weight changes, so many other outcomes related to design the profile of the product. And I will present only some of these the secondary outcomes. So as far as the characteristics of the women enrolled in the study, as you can see, the majority out of them, more than 60%, were first users, so new users of hormonal contraceptive. And also in terms of number, the two groups were well balanced. The weight was similar, the BMI was similar, the number of current smokers in both groups is around 20%, EV smoker very low, 3%, family history of VTA 2%, family history of arterial thrombosis also very low. The only difference between the two groups was the mean age, as you 31 years for in NOMAC group and 29 in the levonorgestrel group. Actually, I don't think that this difference may be very important from a clinical point of view with respect to the analysis of this data. And as far as the VTE risk, as you can see, the risk of deep venous thrombosis and pulmonary embolism was comparable in the users of NOMAC-E2 in those taking the contraceptives with levonorgestrel. Here are reported the number of events with NOMAC, 2 per 10,000 women here, and these 3 is the number with levonorgestrel. And also the hazard ratio has been calculated. This is the Creu, and this is adjusted hazard ratio, adjusted for age, BMI, current duration of OC use, and family history on the VTA. And as you can see, the hazard ratio is 0.59 with a confidence interval. The upper is 1.35. And in the slide for precision are also reported the number of events reported with other kind of hormonal and non-hormonal contraceptives that represent the women that stop the use of this product and start to use other contraceptives. But actually, these do not enter in the final analysis. The analysis was only performed on these 2 groups. And as far as the secondary outcomes, also as far as the arterial thrombosis, as you can see, also the risk is very, very low in both groups, and there is no difference between the 2 groups. And as far as other secondary outcomes, I decided to show the data on weight gain, because weight gain is one of the most important reasons for discontinuation of hormonal contraception. As you can see in this study, there is no, the increase in the weight is not higher in the NOMAC-E2 users than in those taking levonorgestrel. In other words, as you can see, there is a little trend to increase the weight in both groups, but the trend observed in the NOMAC group is lower than that observed with the levonorgestrel group. However, because there is a great overlap between standard deviation, this difference does not reach statistical difference. And another important point is acne. The study is not focused on study acne, so it is to evaluate the effect on acne. There is not been used a devoted score of the acne, but as you can see, a score was performed on the basis of question that has been made to the women, and you can read here the question, and a score has been established. And also in this case, you can see the non-inferiority of NOMAC with respect to COC with levonorgestrel. In that also in this case, the trend is toward an improvement, but from a statistical point of view, it's important to show the non-inferiority with respect to levonorgestrel, that is the comparator. And another important point, mainly also in the past recent year, there was a very important discussion about the depressive disorder, mood changes during hormonal contraceptives. So also this risk has been compared, and you can see these in this slide are reported newly diagnosis or worsening of the existing depressive disorder. All the depressive disorder included in this analysis were treated by psychiatrists, so were a very important depressive disorder. And you can see the number, the standard deviation, there is an overlap, so there is no statistical difference, but as you can see, also the group of NOMAC, there is a similar, the number of event is lower, or even if there is no statistical difference between the 2 groups. So no no important worsening. And a very interesting finding is about the efficacy in a real life setting. I think this is an important observation. And as you can see, as far as the unintended pregnancy, the number observed with NOMAC-E2 is significantly lower than that reported with levonorgestrel contraceptives. And this difference is very important, and particularly evident in women aged less than 35 years, and so in in young people. So an interesting finding also for our clinical practice. I think that there will be discussion about this issue. And this is, I think, the last effect that I will present. This is the serious adverse event observed during the follow-up period. And also in this case, there was no indication that the association E2-NOMAC has a high number of serious adverse events than levonorgestrel users. So the conclusion of my presentation and the speech about this preliminary data is there was no increase in the risk of deep venous thrombosis and pulmonary embolism in the NOMAC-E2 women compared to women taking pills with levonorgestrel. The non-inferiority limit of the hazard ratio 1.5 was met, so the study has been well conducted, and the hazard ratio, I remember, is 0.59 with a confidence interval, the upper is 135. And the women taking NOMAC are not a higher risk for other important effects, depressive disorders, weight change or acne changes compared to the women taking levonorgestrel. And the last effect is that the risk of unintended pregnancy was statistically significantly lower in those taking the NOMAC-E2 versus levonorgestrel. Thank you very much for your attention.
Thank you very much, Franca, for this excellent talk. We have already several questions, but as I said in the introduction, we will have the discussion at the end of the second talk. So now Ali will take over for the second speaker. Thank you for this talk.
Okay. Well, thank you very much, Anne, and may I add my welcome to our audience. This is a breaking news webinar, and we've had a couple of such webinars in the past. So we'd like to swiftly move to the second speaker, and it is my distinct pleasure to introduce my friend, Professor Joaquim Calaf. Professor Calaf is the honorary professor of Obstetrics and Gynecology in the Autonomous University of Barcelona School of Medicine. And until recently, he was the head of the Department of Obstetrics and Gynecology at the University of Hospital de la Santa Creu Sant Pau. And if you go to Barcelona, you must go to his hospital. In addition to being a fantastic hospital, it also is a work of art. So Professor Calaf is going to talk about the latest evidence of the role of estrogen in oral contraception. So Joaquim, the microphone is yours, and you have 25 minutes, and we already have 2 minutes to spare. Thank you.
Thank you very much, Ali, for this nice introduction, and also thank you to the Society and to Terramex for this kind invitation to participate in this webinar. I think that after having heard what Franca explained us, it's important to see how this new information reinforces the position of the different brands available in contraception, and specifically those containing natural estrogens, 17-beta-estradiol specifically. Those are my disclosures. And what we are going to do is just to discuss what this new information is contributing to the 4 main pillars taking part in the process of counseling in contraceptive advice when dealing with potentially new users for contraceptives. And basically efficacy, safety, cycle control, and added benefits. And obviously we will begin by safety. I think that we will all agree that no woman is ready to enter in a danger by trying to avoid an undesired pregnancy. So safety is paramount when considering a new product to be part of the choices for women entering in a contraceptive process. And we have to pay homage once again to the idea of Ludwig Haberland that as early as 1931 proposed his hypothesis of administering high amounts of progestogen, mimicking to some extent what happened in the cattle he had the opportunity to observe in Austria, in his hometown of Graz, and blocking ovulation efficiently. But there were a number of barriers, probably the most important of them, the inability of produce amount of progestogen enough to put a given product on the market. And this barrier has been clearly overcome at Calaf-Alsina lab in Mexico, where Luis Miramontes has been able to isolate norethindrone from a very available Mexican yam that made the industrial production of this progestogen possible, and consequently the possibility of making available to women this new way of avoiding undesired pregnancy while having sex. But what was conceived as single, containing only progestogen, curiously enough, arrived to the market with different amounts of estrogen. It was due to the fact that when Gregory Pincus was just studying in the field in Puerto Rico, the efficacy and tolerability of the product, observed that the combination with estrogen improved clearly the cycle control, and consequently, this was something that could add a value on the combination, and it was considered something completely safe and irrelevant in terms of the impact on safety of the oral contraceptives. But the bad surprise arrived soon, and what we see here is an historical piece. This is an autopsy report of a girl named M.A.R., which is the acronym of her name. She was a physician. She was 27. And in the report, we can read that the potential cause of death was massive pulmonary embolism of unknown etiology. And the only incidents reported in this file was that she was taking Enovit. So first evidence that the relatively high doses of estrogen in these first preparations of oral contraceptives were able to change the panorama and open what will be in the future a source of consecutive pill scares that are very much concerning those working in this field. And I really like very much this slide because it reflects to which extent the content of ethinyl estradiol in a pill is relevant in the risk it's inducing of presenting VTE. This is a slide that arrived practically 15 years after the arrival of the contraceptives to the market, produced in the group of Pablo Westerholm in Stockholm. And in the upper part of the panel here, you see, here you have in the ordinates in percentage, the share in the market of the different preparations according to the content in phenylestradiol or estrogens. Probably 75 was mesranol here. What you see that we have three different waves. One is the one of 75, the one of 50, and the one of 30 that remark 1, 2, 3 different zones, the one dominated by the highest dose, and then this last practically being shared between 30 and 50. And in the lower part of the panel, you see the incidence per cases in 100,000 users per year. And you see from 1965 to 1978, how the number of cases identified in the Swedish registries of VTE have been decreasing as the content in phenylestradiol has been decreasing too. Clearly meaning that it was basically or essentially phenylestradiol content was determining the presence of VTE in among the users. And that in fact is reflecting what Franca has just shown to us. And she very clearly stated that these differences are not statistically significant due to this lack of significance in the upper part of the deviation. But we have to remind that this is a sample that was designed to prove non-inferiority, and I would advance that by widening the sample, we would get very probably a significance in these differences. But what also is relevant for me is that when we look to what the majority of women are using, because we cannot say that preparations with LNG are the most used in Europe, is that this difference become more clear, and very probably if these differences were analyzed, they would become clearly significant. And finally, I think it's nice to see that ex-users have an incidence that is very similar to those using E2 NOMAC as a contraceptive preparation. And I think it's a nice message. I think those are good news that reinforces the whole idea that biological plausibility and previous experiences with the other pill containing also 70-beta-estradiol transmits is that preparations with natural estrogens are, in terms of VTE, clearly safer than those containing phenylestradiol. And we can ask ourselves why this happens. Franca has already commented some details that could explain this difference. We have that phenylestradiol has this radical here that changes things when the molecule is arriving to the liver. And we know that arriving to the liver induces a number of changes in proteins that are not induced either with 17-beta-estradiol, which reaches the circulation easily by a physical process of micronization that does not change the chemistry at all, just making easier the passage through the gut and also arriving to the circulation, or with a valerate form by the addition of valeric acid. And insisting in what Franca has already said, but practically focusing specifically on sex hormone binding globulin, what we see that is by giving estradiol, that will be the reference here in terms of SHBG, when you have one when you have one in the preparations containing estradiol, we have 600 times more the concentration in the circulation of SHBG. And it's relevant because sex hormone binding globulin, since the beginning of this century, has been pointed out as a potential surrogate marker for prothrombotic events among users of combined oral contraceptives. And why is that? Well, I also like very much the light. I would say that this is my favorite. And this comes from Leiden School in Holland. And the paper is very interesting, but I have selected these two figures. Here on the left, what you have is the SHBG levels plotted against another parameter, which is the resistance to the activated protein C. What is protein C? Protein C is a anticoagulant, natural anticoagulant produced by the liver too, and the resistance to this procoagulant is well known to correlate with the risk of VTE. Thus, these two parameters are probably not related in terms of inducing coagulation, but reflect to which extent the liver is changing his way of secreting a number of proteins related to coagulation. And we see in this other chart a different representation is to which extent the different preparations are changing in percentage the amounts of SHBG. And what you see here is that there are three clear bars. One is here on the left, and this is those preparations that are well known not to be able to change SHBG. This is LNG IUDs, no hormonal contraception at all, or copper IUD. Here is the reference product, as you heard before from Franca, and admitted by Emma, is the preparations containing LNG. Here are those other preparations being more anti-androgenic, let's say, like drospirenone, desogestrel, or cyproterone acetate. And here we have the patch and the ring, which have a very wide variations, but are also known to have difficult to establish, but somehow higher incidence of VTE. So this is clearly a marker and direct proof of the relation existing between the changes that a given product can induce in the liver and the potential risk of VTE. And we come to the other arm of this counseling, which is efficacy. And it's clearly important to review it again. Why? Because if we're speaking of something that looks like being weak in its effects on the body, it can be suspected of being not efficient in terms of avoiding unwanted pregnancy. But Franca has already shown what happened in the study, and this is relevant in a moment where there are a number of doubts on effectiveness in general of contraception at European level. And I have just brought here as two examples. On one side, in the side of the doubt, these questions posed by the workshop of the European Society of Human Reproduction and Biology in Capri, where they have been asking themselves, why this ineffectiveness in contraception? And the answer given by a working group where you probably can identify a number of well-known names like Natalie Chava Buffet, but also Iñaki Lete, Paloma Lobo from Spain, Rosella Nappi from Italy, and Gunter Hösler from Austria, and Christian Fiala, where they identified very clearly the culprit of this situation, that was the missing pills process, the forgetting to take the pill, and opening windows without treatment, where the negative feedback that is closed by the administration of the content of the pills get open, and FSH can stimulate a cohort that could arrive to ovulation. And I would like to describe this busy slide. I am sorry for this being so busy. Let's say that the bottom line is here very clearly. Pearl index in SAMBA study, which was the pivotal study aimed to determine what was effectiveness of E2 NOMAC, is 0.38 versus 0.81. It means the double here for the pill containing ethinoestradiol and drospirenone. But when we go to the details, there is a first one, which has already outlined by Franca in the other set of data. It is that among the most fertile subset of the sample, those women being younger than 35, these results are very clear in both groups. Also that here, in the case of E2 NOMAC, there is a very clearly significant result where the coefficient interval is not embracing the unit, is 1 to 0.9, and that these results calculated as Pearl index are also obtained when you just analyze the same data through the live table analysis. So this product is gentle with the liver, but is very active in suppressing ovulation and ascertaining that unwanted pregnancy will be ascertained. And if we want to analyze briefly what are the reasons for that, we see that NOMAC has a long half-life that offers a 24-hour protection in the case that the lady is missing a pill. So this window is not getting open until 24 hours later. That when you deal with monophasic pills, it is not so easy to forget. It's easier to remember because you are taking that practically every day. And also that when there is a very short hormone-free interval, so being this preparation of 24/4 versus 21/7, then you have a shorter opportunity to open the window to the hypothalamic pituitary system stimulating ovulation at the level of the ovary. So taking all these three mechanisms together is a good explanation of this high efficacy of these preparations. And finally, we enter to cycle control. And it is also clear that a woman taking a hormone would like to have friendly menstruations. Friendly menstruation would be short, scanty, predictable, and this is probably very well obtained with this preparation containing 17-beta-estradiol. What we see here is what happens with the sample in the past study we have been commenting, and you can see that even 50-some%, both in the group of NOMAC or in the group of LNG, were taking the pill as a contraceptive. Practically 1/3 took it for added reasons, together with contraception, and about 10% took the pill only for other reasons that are brought with the pill without needing contraception. And if we go to the right panel here, we see also two different parts. One will be commented in the next slide is to some extent a number of different indications. But here, the most frequent reason to use the pill besides contraception is looking for a gentle menstruation. Here you have painful bleeding, irregular cycle, and heavy or prolonged bleeding. So all those girls wanted a friendly menstruation, as we commented before. And what we get when we compare E2 NOMAC or NOMAC-E2 to a combination containing ethinyl estradiol and drospirenone 21/7, the number of bleeding or spotting days with the preparation containing natural estrogen are less along the 4 reference periods of 90 days during the study as compared to the drospirenone and ethinyl estradiol. So we can say that these menstruations are friendlier and gentler. But at the same time, and it's important to comment that to the future users, there is a number of cycles where the user won't have a menstruation. I would say that with the preparation of E2 NOMAC, we have from the very beginning in a growing way, from 20-some to 30, practically 30-some, 31 number of cycles where the user won't have menstruation. And this is very relevant to comment to the users, the potential users, because knowing that nobody will be afraid if the menstruation is not appearing. On the contrary, they will be probably happy of not menstruating and not having all the disturbances which are added to that. And it is clearly different to what we get with the conventional oral contraceptive containing ethinyl estradiol, in this case with drospirenone. So remember to comment to the future users, with this preparation, probably you are going not to have menstruation in some of your cycles, but at the same time, this is something which is clearly not related to the risk of undecided pregnancy. And among those other added benefits, it is not probably the moment of comment on that. We could just devote a whole presentation on this topic. We have, as we said before, dysmenorrhea, disturbances of the menstrual cycle, premenstrual syndrome. Franca has already commented on acne, and also commenting on body weight, mood, libido, and risk of depression or psychiatric changes. So taking everything together, I think that it is clear that deep preparations containing ethinyl estradiol are more prone to give problems around menstruation, and that the combination containing 17-beta-estradiol is much milder, gentler, and friendly in terms of making menstruation more pleasant. And we change to a very final topic, which I think we need to comment. I just took the 1 week before today, a screenshot of PubMed with the search contraception COVID-19. We have in the last 2 years, it could not be before us, it's logical to infer, 199 results and growing. You see that only on September 2021, we had already a number of papers more than the whole year before. And I think it's relevant for a number of reasons that we are going to comment very shortly. Look, this is an explanation why we establish a link between hormonal contraception and COVID-19 morbidity and potentially mobility. And it is because from the risk factors, we got to, in the course of the disease, to hemostatic abnormalities were linked to the disease very clearly and reflected in changes in the platelet count and sharp increases in dimer D and other coagulation markers that end up by having as a severe complications in cases of intensive care unit admitted woman in venous thromboembolism, myocardial infection, and intravascular disseminated coagulation. Thus, we have been speaking about preparations having different impact on coagulation. It's logical that people think on to which extent can this kind of medication impact on the risk of thromboembolism among women suffering of COVID infection. And this is a very unpleasant figure that I wanted to bring here, because it's establishing for the eyes of the potential user the risk of clots between infection, vaccine, and pill. And I think it's important to clarify to users that this link does not exist directly. Just conversely, we have been observing that first, women do better than men dealing with the infection, and secondly, probably women having a certain given level of estrogen, whichever the estrogen it is, will do better than those having a very low level of estrogens. And however, the different scientific societies, like the Brazilian, the Spanish, or the Italian one, have not reached a consensus about what to say to the users in the moment of being exposed to the infection and taking oral contraception. But fortunately, I would recommend you to review this nice paper from Gynaecology, published in our journal, the European Journal of Contraception and Reproductive Healthcare, which in a very well balanced way, he is commenting what can be the final idea is that nobody has to stop anything she was taking for contraceptive, except in the case of needing to be admitted in an intensive care unit and being submitted to treatments that won't allow for the regular intake of the pill as should be done. So let's summarize and conclude. I think that we have to take home 4 main messages. One is that preparation with 17-beta-estradiol are associated with a lower risk of PTE just because they are not changing in the same way the production of hepatic proteins that intervene in the process of coagulation. That, however, being very gentle with the liver, those combinations with 17-beta-estradiol are very active, avoiding unwanted pregnancy. That there are a number of added benefits that are linked to this low power estrogenic priming, like cycle control, short or tiny menstruations, and decrease in the peripheral manifestations of the progestogen contained, like acne or weight gain. And finally, that in the framework of COVID infection and the vaccination too, the epidemiology suggests that 17-beta-estradiol is bringing protection against severe forms of the infection, the natural one being held by the woman, and that in the case of having to prescribe a new combination, this is something to comment with the potential users as an advantage in terms of having a very friendly product for coagulation. And I think that we have put the evidences that Franca has brought to us in the context of contraception today, and I will be pleased to answer the questions that can arise. Thank you very much.
Well, thank you very much, Joaquim. It's amazing that we've actually, to the minute, have adhered to the time. So thank you to the two speakers. And I think Franca has presented this very new data, which we need to think about and incorporate into practice. And Joaquim gave us a real interesting overview about the role of estrogen and especially estradiol in this new era of combined pills with natural estrogens. So we have some interesting questions. I'm going to take them as they came, and Professor Gompel is also going to help me if I need help. So we have a question. This is to Franca, and we have time, so we can expand on some of these. I think that there's a question about the secondary outcomes. You know, do we have, or do you know about the comparative data with NOMAC-E2, LNG, and other pills in relation to acne, in relation to weight gain, and in relation to mood changes? Franca, you're muted. You need to unmute yourself.
Yes, thank you. Yes, thank you for your question. And obviously, there is a primary goal, and the other is to have an idea of the general effect of a preparation compared with the best comparator of the primary goal, that is venous thrombosis. And I think that the data I presented are very interesting because, as also Joaquim underlined, the weight gain and acne and depressive disorders, mood changes are important side effects of hormonal contraceptives, and very often women discontinue hormonal contraception because of this. Obviously, this study has been performed not to understand the real effect of NOMAC in acne women, because also the score that has been used has not validated. So just only to have an idea what happened in this kind of women with moderate acne and so on. So it is not a study designed to show this particular point. So it is not performed with a validated score, but it's very interesting to show that when we compare the data according with the other contraceptives, that is the goal of the study, the number of women with a worsening or with the negative mood and so on are not higher than the best comparator for VTE, that is levonorgestrel. This, in my opinion, is that okay, at least in Italy, you have some guideline from our authority, and that is that because the lowest effect of levonorgestrel can be considered the first choice, okay? Today, we have another kind of pill with the same effect on VTA. But important is also to know, and about the others, okay, NOMAC have a worsening effect or no? Okay, no, it don't have a worsening effect, but the effect are, okay, no increased, it is normal, and probably there is a trend towards an improvement. So I think that the data obtained from this secondary analysis point is interesting, just to have information in our clinical practice.
Thank you, Franca. Do you have any comments, Joaquim, on this?
No, I fully agree with that. Yeah, I think it's okay.
Yeah, I mean, I think the point you make about the rules in Italy, I think that we're getting to a new paradigm in combined oral contraceptives, and I think the estradiol-based preparations are going to sort of start to make some impact into the choices. So thank you very much for that answer. But stay with us, Franca, because there are a couple of questions on the VTE risk. So one question was, obviously you've alluded to the fact that the comparison was between NOMAC-E2 and LNG, but in the slide on the comparative risk, you had 3 other groups, which are other OCs, other hormonals, and X users. Do you want to, I mean, obviously, that is not the intention of the past data, but do you have any comments about the other 3 groups?
Yes, I think that the important is the third group, that is hormonal contraceptives, because in the other COC group, contraceptive, so the 4th group before X users, if I remember, there is included also IUD, so it is quite different, so I cannot, but in the group with the hormonal contraceptives, actually there are the pills that are in the market and are normally used by physicians, that is pills with ethinyl estradiol. And I think also you have not the statistical analysis of this data, but I think that is nice to see the number, because the numbers are quite higher than the one reported with natural estrogens. And this is an important information, because until now we have only the pills with levonorgestrel, but now we have other products, and you can refer to these in the choice with a very low risk. So the third group respect what happen with ethinyl estradiol pills, and the risk is higher with respect to that of natural estrogens, and also with the levonorgestrel, obviously. And this is reflect the epidemiological and data present in literature. So there is no statistical analysis, but I think that the idea that you can have is very, very interesting.
Yeah. I mean, I think the trend makes sense.
Yes, the trend.
That is the important thing. And one of the points is that these real life data are very important for us counseling our patients and telling them about what is going on. Well,
if I may add, especially the fact that women were a little bit older with NOMAC estradiol pill. So the age increased the risk in VTE. It's also increased the efficacy. In terms of efficacy, it's increased, of course, the efficacy. But in terms of VTE, age is an important factor. So it could be this. What is your opinion to both speakers about the place
Yes.
of contraception in women over the age of 40.
Yes, I think that to have a pill with natural estrogens for women of older reproductive age, that is mean after 40, I think is very, very good, because in this group of women, there is a spontaneous increase of the risk of venous thrombosis. So to have something that have a lower effect on coagulation factor and so on, I think that is very important, because it's true that the VTA risk with the levonorgestrel is the same that NOMAC. But if we compare the route to obtain this similar effect, the truth is completely different, because in the case of ethinylestradiol and levonorgestrel, ethinylestradiol stimulate and levonorgestrel counteract. So there is like a war. And in the other, there is no important effect on coagulation. So very soft from a metabolic point of view. So I think that this is an important thing to realize in women of older reproductive age.
So maybe a question to Joaquim as well. There are a question in the audience about the comparison head-to-head to the cycle control of pills with the same administration, 24 days and 4 days of stopping. Have you seen anything on that? Any data on the comparison of cycle control with pills have the same scheme of...
Okay. Well, before answering your last question, I would like to thank the opportunity to make a statement I forgot to establish in my presentation. I think that all those data concerning VT risk can't change the eligibility criteria for the administration of contraceptives. Those are good news for those complying with the criteria, but you are not falling in the error of administering pills to women being at risk, thinking that these pills are safer, because we'll have once again a new pill scare. So keep within the old eligibility criteria to administer oral contraception, even knowing that the risk is lower with the preparations containing 17 beta-estradiol. Said that, and trying to answer to Anne's question, I would say that in general, any preparation with a short hormone-free interval will be more efficacious than those having the 7 days. But I have seen in the number of questions some contributions from John Guillebeau concerning the different extension of the administration, and asking ourselves to which extent these intervals are needed. If we go to the story, and sometimes the story helps a lot to interpret the reality, we have these intervals just to try to mimic the normal cycle, because somebody in the Catholic Church in Boston promised to accept contraception if it was mimicking the natural cycle. That it's evident that had never happened. So why we have to continue to adhere to this schedule of 21/7 or 24/4, inducing withdrawal bleedings which are senseless if women do not want it? So the first question should be, when offering oral contraception, is, do you want to bleed regularly or not? And probably the extended regimes should substitute what is classical at the present time. And I don't want to skip your question. I cannot now make a summary of what would be the real efficacy of the combinations being 24/4 with ethinylestradiol as compared to 17 beta-estradiol. But they will probably be similar, but at the same time will be also related to the half-life of the progestogen content. So I think that both factors count. The wideness of the period hormone-free and the half-life of the progesterone contained in the preparation.
Okay, well, thank you very much. That's a very comprehensive answer. There is actually a very interesting question, which again, on observing on the 5 groups that you had, Franca, in that presentation. And they've noticed that actually in the group which has other hormonal contraception, there was a much higher rate of depression. And the question was, why that difference, you know? Do you have any answer? Unmute yourself, Franca, you're muted.
Sorry for the mute.
That's okay.
But I have my particular idea, because also I saw this data, and probably is, we can say, selection bias. Probably some people have been moved not for worsening of depression, but also because they started to use other kind of drugs that can interfere with the contraceptive and so on. I don't know which kind of reason, but probably in this group has been grouped women with a particular condition. So it is a data only related to a selection bias of this, more than selection, women with the problem related to their depression from a pharmacological point of view or something else. So they have been moved from hormonal contraceptives and they received non-hormonal or other kind of contraceptives. This is what I think was about this different data. Also because, okay, the confidence interval, the standard deviation is very, very large. So it means that it is a very heterogeneous group of women. So it is difficult to give a precise idea. But I think my idea is that only other things is the reason because women have been moved from another contraceptive, non-hormonal contraceptives.
Yeah, I mean, I think I agree. I don't think we can make much out of this observation because, as you say, it's a heterogeneous group, so it will have people who may be taking progesterone-only methods and IUDs, and it's a smaller group, obviously, than the comparators. Now, obviously, if you were a pill enthusiast, you may actually say the pill makes you happier rather than the other way around, but that is something that we'll leave for another day. Okay, there are more questions. I don't know whether Anne has picked up the latter ones, but
yes, there are some questions of other aspects. One question about the bone tolerance of this pill, and also another question about the cardiovascular or metabolic aspects. Do you have any clue on that?
Yeah, so there was a question to say, you know, these products, this pill may be attractive to young people because of the good effect as far as acne, and obviously also on the efficacy side. But what about bone density and bone mass? Because the view was that the estradiol is a weaker estrogen in a way. So do we have any views on that? I don't know whether Joaquim
I have views, not data. I'm sorry, I don't have data. I have views. Yeah. And probably would be nice to have data on it. But as a general idea, if you have an amount of estrogen that is able to fill the classical window of estrogen, allowing for a good coupling in the bone turnover, there is a very low risk of having a problem. But at the same time, what is important is the added factors helping to maintain bone turnover. Exercise, for instance, body mass index, etc., etc. So this is something that has to be carefully evaluated user by user. So if you have a user where the tendency is not to be active or has other risk factors other than their immobility due to any other cause, etc., that should probably be checked. But in general, I would say that the preparations containing more than 1 milligram, we know from the treatments in menopause that 1 milligram is good enough to maintain bone in a woman where the ovary is not working in general, and from the all studies by John Studd, etc. And I think that this can give a certain confidence, but I have to admit that it would be nice to have data on that directly.
But maybe the sensitivity to estradiol is, the bone sensitivity to estradiol is not the same at the age of 20 and at the age of 60 or 55. So I don't know if you can say that over 1 milligram it will be safe for the bone. Do you have an idea on the endogenous estradiol amount under this pill, the antigonatropic effect and the estradiol level?
Well, Franca, go ahead.
Okay, I would like to make a comment on the question before also, because I completely agree with Calaf comment, because, okay, there are hormones, but there are also the lifestyle. And it is very, very important to focus also on the lifestyle of our young women who approach to contraception. And in this field, at the younger age, the bone is a very complex issue. And we have no generalized information about this issue. And somebody think that natural estrogens may be better than ethinyl estradiol because the biochemical changes induced on IGF which take part in the bone metabolism are lower than that induced by ethinyl estradiol, and much more is lower IGF, and this is represent in like a stimulus for bone. So comparing ethinyl estradiol probably should be better to use 7-beta estradiol than ethinyl estradiol, always because of the stronger effect on IGF. But actually, at the present time, we have no comparative data. We have no possibility to give a right information about this issue. Yeah. It is very important. But I don't think that 70-beta should have a negative effect in a young girl.
Yeah, we need to move from this question, but I think for the colleague who asked the question, we can be reassuring. I think the IGF data you talk about, I think the lifestyle issues are all very important. So, and the fact that we don't have evidence, for instance, on the real outcome, which is fracture risk and that sort of abnormality. Okay, so we just moved to another question. And this is I think Joaquim mentioned that Professor John Guilbault is on in our audience, so we're delighted to have him. And as you know, John in his writings has been promoting the idea that we don't need a pill-free interval, that the normal way, the standard way, the real way we should be talking to people about is to take the pill continuously. And he was questioning the 24/4 regimen, and Joaquim, you've answered that. But can we ask just for an opinion, because it's more the psychology, isn't it? It's the psychology of contraception, of how our two experts view this idea of eliminating the pill-free interval.
Franca, what do you think? Agree more with John. I think that these intervals are completely senseless. From the time of the book of Elsimar Coutinho, just dealing with the issue that menstruation is senseless when taking oral contraception, I think that here is a very important cultural aspect. So I think it's the woman that has to say if she wants to withdraw or not, because the meaning, let's say that I have the general feeling after a long time dealing with women, that men tend to be monotonous and women tend to be cyclical. And being cyclical has a meaning also in a number of other issues along life. And it has to be the woman's choice to see the menstruation or the withdrawal bleeding or not. So what is important is to transmit to the users, which are not patients, that the alternative exists. And it's up to them to make the choice of having that or not. But I think that we should not be bound to the regulations of having to administer the product in the way it has been designed at the very beginning, that menstrual strategy should be possible, and we should have the habit of offering that to the potential users in the future.
Well, we will look at the rest of the questions and try to answer them later individually.
I think there is an interesting question about the length of the study, suggesting that maybe the risk of VTE could vary after 2 years instead of 1 year because of cumulative effect of estradiol. What is your opinion on that?
I think, okay.
Go ahead, Franca.
Okay, thank you. I think that year of observation is a good time to give an idea of the risk of venous thrombosis, because we know that the risk may occur at the beginning of, we can say within 1 year, okay?
The first 3 months, and
yeah. So
then remain stable, but not
increase. Yes, and so I think that 2 years is enough to have an idea about VTE risk. Yes,
I agree.
It's a rapid effect instead of the effect of breast cancer or other
long-term effect, sure.
So I think the conclusion to this answer to this question is that it's the other way around. It actually, the risk is higher in the first 6 months rather than a cumulative effect. One more comment before we go to close, which is to say that we can, looking at the data on efficacy and on safety, and comparing it to data we know from the estradiol valerate dienogest combination, can we now say that estradiol-based combined oral contraceptives seem to be safer than the ethinyl estradiol? They're not necessarily statistically significant safer from a risk point of view, but on the whole, they're in the sort of safer category. Would you agree, our two expert speakers?
Yes, I think that you have the past study with estradiol valerate and dienogest. It was the only one until now, and now we have another very large a study performed on a very large population, because they are 100 women. So the number are very high, and I think that now we can start to think that 17 estradiol or natural estrogens are really better than ethinyl estradiol with respect to venous thrombosis. And I think that data obtained with NOMAC confirm data obtained with estradiol valerate and dienogest. This is my idea.
But still, we have to highlight the fact that we have to select women with no contraindication, because the risk remains. I think it's very important to say that as well. And so
I already said that, but I think that what would be nice is just to explore the possibility of pooling the result of the two studies, because I am convinced that the lack of significance is closely related to the size of the samples. So if we were able to find a similarity between the two samples at the moment of recruitment, that would enable technically to pool the two studies in one observational, let's say, reanalysis, that would be also nice. It is something I have in mind. in my head.
Joaquim, I am not a methodologist and have not enough skills in statistics, but if you look at the rates of VTE in the Clara's study, the rates were higher. They were the same trend compared to the levonorgestrel, but the rate of the VTE was a little bit higher than in that study. So is it proper to combine the two studies? Because they are not randomized studies. I mean, the risk and the risk factors of the population can vary a lot. So I don't know.
Yeah, that's it. But, you know, it's, as you said, a question for the epidemiologists. They have to say that. Yeah, they have to say that, because if you end up by having a more comprehensive sample, by including all kind of people and putting everything together, the number increases and the scope is wider, then the results are more reliable.
Potency of the study, yeah.
I think it's something that has to be evaluated, deserves evaluation. Okay, well, I think maybe that is something that a future webinar of the ESC will deal with. So we need more studies and bigger studies, and we definitely need epidemiology. Can I have a closing slide? So I think we've done really quite well. So thank you very much, first of all, to our two excellent speakers. The fact that we've had more questions as we carried on, as we progressed in this, shows how interesting and how important this topic is. My thanks to my colleague, Professor Gompel, and for chairing and helping with this webinar. I'm going to show a slide which is sort of my take-home messages on this study. So what did we learn in the past hour? Well, this is a large study, though we will probably need larger studies. And it looks at the points that are relevant to our patients: safety, efficacy, and tolerability. The methodology for real-life data is actually robust, and the number of participants is high. I think the next point is that this real evidence, all real evidence data, makes sense to users, and we should be using them as basis for counseling, and the discussion we've just had reflects that. The natural estrogen pills seem to demonstrate a safer profile, and remember that we don't have statistical significance. But one of the interesting things on this slide that Franca showed, which is on the arterial events, it highlights the fact that the combined pill, as far as arterial events, is actually quite safe. The risk is pretty small, and as she highlighted, it's a risk which is mainly seen in people who already have a risk factor. But we should always aim to look to reach neutrality as far as the effect on thrombotic incidence. And I think the data on the absolute figures are overlapping with what is in natural, and obviously they're much, much lower than what happens in pregnancy and in the postpartum. I think we need to also think about the progestins that have been used. It's interesting that we have NOMAC in this, we have Dynagest in the other preparation. And I think the choice of the progestin helps better cycle control and possibly higher efficacy, considering, for instance, the half-life. The surrogate biochemical metabolic markers are reassuring, but we need, as we've just said, epidemiological data. And it is obvious that the 24/4 regimen delivers higher efficacy where it matters: for the young, for those who have busy lives, and for the forgetful. Soft outcomes, I think we tend to put them as secondary, but they are very important to the users. So libido, skin changes, and mental health really, really matter. And I think we need to, in future research, focus on them. I think the secondary outcomes in this study, maybe we can have a deeper look at it. And if estradiol-based products do better, even if they are only marginally better, I think they should be an important consideration where we're moving towards the personalized medicine model. What is your priority? What is your problem? And can we do anything even to give you some marginal improvement? I thought
the two presentations were really, really excellent and give us a lot of food for thought for the way we deal with oral contraception and the way we counsel patients. Can I have the next slide, please? And I'm just going to highlight the fact that it is really the best time to join the European Society of Contraception. It is the best value for money because of the fact that it costs so little. It's about 2 coffees in Piccadilly in central London, essentially, if you go to a very posh coffee shop. I just wanted to highlight that we are a family of experts across the reproductive health spectrum. So in the society, we have gynecologists, menopause experts, epidemiologists, and so on. I just wanted to highlight the fact that in future webinars, we're going to deal with a wider range of issues, vaginal infections. We are planning to do something on HPV testing, when and which test, and probably also handle some of the issues around the menopause. I also wanted to highlight to you is that tomorrow we have the launch of a memorandum of understanding between our society, the ESC and UNFPA, in 2 important regions, the Eastern European and Central Asian region and the Arab state region. And we're very excited about that. And therefore, those of you who work with UNFPA are most welcome to give us views and suggestions and feedback. Everybody in our society has a voice, and we are really looking forward to the Congress in Ghent in May of next year. We would like to see as many of you with us, and we want to essentially really continue this conversation in the way we've done it in this webinar and previous webinars. And I want to thank you all for staying with us. We still have a substantial number of people now, even though we are 5 minutes over time. So thank you very much, everyone. Thanks again to the speakers. Thanks to the central office staff who have been doing fantastic work to make this webinar run so smoothly as it has. And hopefully we will see you again in about 6 weeks' time in our next webinar. And thank you very much. We'll sign off now.